So I'm going to present our study on whether job control contribute to differences in physician-certified sickness absence across office concepts. And it was a counterfactual mediation analysis done in a nationally representative sample. And I'm a PhD candidate at STAMI in Norway. So previous research have found higher sickness absence risk in shared and open workspaces compared to private offices. But very few, if any, studies have attempted to study why these differences occur. So in this study, we draw upon different perspectives from psychology. Specifically, we merge perspectives from occupational health psychology and environmental psychology. And we propose and test job control as a plausible mechanism underlying these differences in sickness absence risk between private offices and shared and open workspaces. So just briefly about the conceptual foundations. A simple but useful definition of job control is that it concerns employees' perceived control over timing, methods, and decisions at work. And we also know that it's one of the most consistent predictors of outcomes in the workplace, including sickness absence. So how do we think that office concepts might influence this? So here we draw upon privacy regulation theory, and this theory argues that privacy is not only concerned with the act of limiting intrusions from the environment and from other people, but it's also concerned with the behaviors that we have available to pace and regulate social interaction and access to the self. And by doing this, people can set favorable conditions for goal-directed behavior, such as the completion of primary work tasks. So now I have to skip over a lot of interesting psychology stuff that I don't have time to go into, but it sort of sounds that this might influence employees' perceived control over work. At least I think so. So given that privacy is lower in shared and open workspaces, there are several systematic reviews that indicate this. We can also assume that this condition-setting control may be restricted, so that employees might have fewer means to regulate social interaction and also access to the self, and that this might influence employees' perceptions of job control negatively. Okay, so in terms of office concepts, we differentiated between 5 different types. So it's private offices, which is like one-person cell offices, and then we have conventional shared room offices, which are enclosed rooms with a few employees and fixed seating. And then we have conventional open plan offices, which are larger open spaces with more people, but still fixed seating. And then there are 2 equivalent non-territorial types, which are the same as shared room and open plan offices, but without fixed seating. So the employees there share the workstations and can choose freely which workstation to use. And then we expected that compared to private offices, these other office types, that we would find higher sickness absence risk in these office types, and we would find lower perceptions of job control, and that this would mediate some of the differences in sickness absence risk across office concepts. And we also controlled for a range of baseline confounders, so age, sex, education level, occupational group, whether the respondent had any executive or leadership responsibility, and also how much time they spent on office work. Data came from the level of living survey on working conditions, which is collected by Statistics Norway. And this is a nationally representative survey, and we used data from 2016. And this survey data was then merged with registry data on physician-certified sickness absence with 1-year follow-up. So this came from 2017. And the final sample then consisted of around 5,500 participants, and they were aged between 17 and 67 years old. They were all engaged in paid work and did all or parts of their work in an office environment, and none of them were self-employed. So just a brief repetition of the study variables, office concepts, 5 categories based on layout, number of occupants, and territoriality. And then job control was a sum scale consisting of 4 items measuring different aspects of timing, methods, and decisions at work. And sickness absence was physician certified, taken from national registries with 1-year follow-up. And we then looked at whether the participant had had any sickness absence in the follow-up period. In terms of analysis, we used counterfactual mediation analysis, specifically the regression-based approach with direct imputation of counterfactuals. And I referred to these references for an accessible introduction. But it basically involves estimating an outcome model and a mediator model, and then direct and indirect effects are then calculated from these models. We used bootstrapping for standard errors and 95% confidence intervals, and we used R for all our analysis, specifically the CMA VERS package, which is a package for causal mediation analysis, which is also very useful. Okay, so after checking whether there were any exposure-mediator interaction, that is whether office concepts and job control interacted in their effects on sickness absence, which there were no evidence for, we went for this simple 2-way decomposition of total effects into natural direct effects and indirect effects. So the natural direct effect is the average effect of exposure fixing the mediator. So the change in sickness absence risk when office concept is changed from private offices to, for example, conventional open plan offices, with job control fixed at the level observed in private offices. And then you have the natural indirect effect, which is the average effect of the mediator fixing the exposure. So change in the sickness absence risk when office concept is fixed at private offices and job control is changed from the level observed in private offices to the level observed in conventional open plan offices. So in terms of results, we saw that both conventional open plan offices and the 2 non-territorial office types, we found significant total effects and also significant indirect effects. And the proportions mediated ranged from 19% to 34%. So this indicates higher sickness absence risk in these office types, and it also indicates that a significant proportion of this increased risk was attributable to lower perceptions of job control. The study has several limitations. As in all observational studies, we cannot rule out unmeasured confounding. Although our results are in line with our hypothesis, we cannot rule out alternative explanations. We also lacked temporal ordering between the exposure and the mediator, although there is less likely that job control would influence which office concept you're placed in. And there might be measurement error in the job control variable, so this study should be repeated with a better measure of job control. And we also had limited information about office features. So we were unable to differentiate beyond what we did here, and we also did not have any information about telework from home in this study. And since in Norway you are fully compensated from the first day of sickness absence, the results might not be directly transferable to other countries. So just to sum up the main contributions, this is the first study that looks at differences in physician-certified sickness absence across office concepts in a nationally representative sample. We're also the first to propose and test a mediator with clear conceptual foundations. We found higher sickness absence risk in shared and open plan offices and also lower job control. And we also saw that there were significant indirect effects through job control. And this is in line with the hypothesis that job control may be one of several plausible mechanisms linking shared and open workspaces to sickness absence. Yeah. So that's me. Are there any questions?